Hello, everyone. A very good evening to you all. Myself, Dr. Sumedha Gupta, and on behalf of Voice of Healthcare, I would like to welcome all the viewers who have joined us. So, today, we are here to present the eighth episode of Detect to Protect, a series of awareness session in fight against the breast cancer. And this session is organized by Voice of Healthcare and supported by Zydus Life. So, in today's session, we'll explore about the vital insights on breast cancer from recognizing the signs and symptoms to importance of early detection, prognostic testing, policy advocacy, and the latest treatment options. So, let's come together to empower ourselves with the knowledge that protects women's health. Before starting the discussion, I would like to share some stats and facts about the breast cancer prevalence in India. Breast cancer in India possesses a significant public health challenge, accounting for about 14% of the global burden. The incidence is rising at 1.5 to 2% annually, with approximately 60% of cases diagnosed at advanced stages, which severely impacts the treatment outcomes. The average age of diagnosis is around 45 years, younger than the global average age of 61 years. And the survival rate varies widely from 70 to 80% in the urban areas in comparison to 50% in rural areas. Awareness of symptoms is really low, with only 20 to 30% of women informed about this disease, and less than 10% participate in the regular screening. Cultural barriers and stigma further impede timely medical help, especially for the women with a family history of breast cancer, who actually are at the 2-3 timer higher risk than the normal. These factors highlight the urgent needs for breast cancer awareness, education, and the healthcare access to address the rising burden of breast cancer in India. And in the light of these stats and facts, to begin with the discussion, first I would like you all to please join me in welcoming our experts, who is going to provide us with insightful information on understanding about the breast cancer awareness. I would like to welcome Dr. Navneet Kaur, Director, Professor, and Consultant Surgeon, UCMS and GTB Hospital. Good evening, Doctor. Welcome to the discussion.
Thank you for inviting me.
You're welcome, Doctor. Moving ahead, I would like to welcome Dr. Devavrat Arya, Director, Medical Oncology, Max Super Speciality Hospital, Saket. So, Dr. Devavrat will be joining us in few minutes. Moving ahead, I would like to welcome Dr. Poonam Patil, Consultant Medical Oncology, Manipal Comprehensive Cancer Center, Manipal Hospital, Bangalore. Good evening, Doctor. Welcome to the discussion.
Very good evening to you all.
Moving ahead, I would like to welcome Dr. Geeta, Senior Consultant, Breast Surgical Oncology and Oncoplastic Surgery Lead, Apollo Women's Cancer Care in Prest Apollo Hospital, Delhi. Good evening, Doctor. Welcome to the discussion.
Thank you, Sumedha, for this opportunity. Thank you.
You're welcome, Dr. Geeta. So let's begin with the discussion. Dr. Navneet, if we talk about the sign and symptoms of the breast cancer, can you please enlighten us? What are the key sign and symptoms of breast cancer that women should be vigilant about?
Yeah, I think one of the most common symptoms that a person can present with is a complaint of a lump in the breast. And other than that, other symptoms like there may be some changes in the skin that they need to be aware about. There may be some kind of a abnormal dimpling or puckering that may appear. There may be some skin changes. There may be some area of redness, or some kind of asymmetry in the shape of the breast, a nipple discharge, which may not be, which may be blood stained or which may be persistent without patient trying to express and check on it. These are the common symptoms with which a patient may have a breast related symptom. Other than that, they can also have symptoms related to spread of the cancer, which may be noticed the first time by the patient. So they may come with a swelling in the axilla, in the armpit area. They may come with a swelling in the neck region. At times, they may present the first time with persistent pain in the back, for which they have been taking painkillers and not getting treatment. So these kind of symptoms may also present in patients who have not had something visible in the breast, but it has spread already, or something in the breast which they have not noticed and it has gone into the system. But the most important thing that a lay person should be aware about is what their normal breasts look like and feel like. And if they see there is a change in the uh, texture, some area may feel harder, it may appear abnormal compared to the normal appearance a person is used to seeing, or there may be a one can palpate or feel a lump in the breast. So these are the common symptoms with which person should be aware, so that if they notice any of these, they should be reporting to the doctor for opinion.
Thank you, Dr. Navneet, for providing us with the sign and symptoms. In following up of that, I would also like to know, how can women tell the difference between the normal breast tissue changes and the potential red flags for the breast cancer, the alarming signs, I would say?
See, everybody, all the girls should be encouraged to know what their normal breasts look and feel like. And any girl who has already undergone menarche and has developed breast should be looking at them on a regular basis. If they may be not always equal, even by congenital development. There may be a problem with the nipples. It may not be normal. It may be kind of a inverted or a retracted nipple. So, if these are during the development of the breast, these changes are normal. They need not be alarming. But if something like that happens later in life, that the nipple changes its appearance, it starts to look indrawn, the asymmetry of the breast is visible, which was not there earlier, and they should also feel how, they should also know how their normal breasts feel like, because within the normal spectrum there is a very variation in along with the menstrual cycle, along with the age, these changes keep happening. So
Yeah.
in the advanced stage, for example, breast will feel very soft and supple because they are mostly having a lot of fat. In a younger breast, it is a lot of tissue of the breast which is going to produce milk, glandular tissue, so they feel much firmer during the period when they are having these cycles and involution and lactation and all these changes. So it may feel very heterogeneous. Some areas feel thickened, granular kind of a feeling. So at every stage, if they keep looking at their breast and they keep touching, they will know what their normal breast feel and look like. And if there is something which is not feeling normal, and things I have already listed out, they start looking asymmetrical. One breast, like skin, looks abnormal, dimpled, or there is a redness, or a nipple is indrawn, nipple has gone in, which was in a normal position earlier on, or there is a visible bump, or area of hardness. So all of these, I think, if they are aware what is normal, they would be very easily to pick up what is abnormal. Many things, or many of these symptoms also fall within the range of a normal spectrum. So they are not always a sign of a cancer. For example, the breast lump can be in a situation which is a benign condition, which is not alarming, which is not going to spread beyond breast, and we don't even recommend any kind of surgery for that, right? So out
Yeah.
of 10 patients who will come with a breast lump, 7, 5, 6, 7 will not have any cancer. Only 3 or 4 will turn out to be a cancerous lump. So all these symptoms, presence of a lump, even a nipple discharge, they all can be normal also, but there is a threshold between the normal and abnormal, and that only a clinician can really differentiate. So it is the responsibility of the person to know what it is and seek opinion if they see a change. Because if you are scared, if you make your own diagnosis, then problem lies there.
Yeah. Thank you, Dr. Navneet, for these insights onto that. And I think this is going to be really valuable for the people out there who are listening to this. Moving ahead with the discussion to Dr. Poonam, I would like to know, are there any specific demographic group that should be especially attentive to recognizing such symptoms, or maybe I would say certain age factors or related to such things?
Yeah, so the biggest risk factor for developing breast cancer is age. Increasing age itself is a risk factor for development of breast cancer. And it was seen earlier that breast cancer was a disease of, say, above 50 years of age group. But now we see many women between 35 to 50 years of age also developing breast cancer. So, yes, there are demographic groups which should be particularly attentive to recognizing symptoms of cancer, women aged 30 and above. As I said, that there is a shift in the age of development of breast cancer. So, the risk of breast cancer increases with age, and women above 30 years of age should follow all the screening guidelines like breast self examination, what Dr. Navneet so beautifully explained. Women with a family history of breast cancer or even ovarian cancer should be more vigilant. Women who are known to have some genetic predisposition. Now, many women are aware, general population is also quite aware that there are genetic mutations such as BRCA1 and BRCA2, which puts a woman at a heightened risk of developing breast cancer or ovarian cancer. And if a woman knows that she's carrying one of these genetic mutations, she should be going for monitoring the breast more closely. Pregnant or breastfeeding women also should be told to check the breasts because breast cancer is known to occur even in pregnant women or lactating women. And sometimes these changes of pregnancy, changes of lactation could be confusing. So, if they feel that there is a lump which was not noted earlier but has come up in due course of time, they should seek an opinion from the doctor and not leave it related to, not think that it is related to pregnancy or lactation. Women with lower socioeconomic status should also be made aware, because they're, due to lack of awareness, due to lack of health care, they face barriers in coming to the hospital to seek attention in proper time. So they should also know that there is something known as breast cancer. This is how it presents, and if there is anything suspicious, they should seek medical opinion for the same.
Thank you, Dr. Poonam, for such insights. In following up of that, I would also like to know, I mean, in your practice, have you ever seen, I mean, so far that what is the range of the patients when it comes to the rural area or the urban population? I mean, is there any thing that urban population is more prone towards such diseases or
Yes, 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 it has been seen. The statistics show that the urban population is at more risk compared to the rural population, and that is more related to lifestyle.
Thank you, Dr. Poonam, for telling us about this. Moving ahead with the discussion to Dr. Geeta, I would like to know what actions should a woman take if she notices any unusual changes in her breast.
So when women see, and especially when, like Dr. Navneet said, it's a lump, which is the commonest symptom, and a painless lump at that. So you see that most of the patients would present with a painless lump, but in advanced stages, because when it is painless, they believe that it is not causing her any trouble, so why should she be going to see a doctor at all? So I think it is important for them to recognize that any new lump that is there in the breast, irrespective of age, should be seen by a surgeon or an oncologist. And then, not necessarily an oncologist, because sometimes they're loath to go to an oncologist also, because they think kuch na kuch nikal hi lenge isme se, so that fear is there. So they should actually go and get it investigated. So triple assessment, as I think Dr. Navneet, I think she mentioned triple assessment. So that needs to be done for every single lump that appears, which is new in a patient's journey. So she should go and get it investigated. So when I say investigated, it means imaging. If you're over the age of 40, then it has to be a mammogram. Sometimes you require an ultrasound along with it. And if you're under the age of 40, usually we would do an ultrasound. But if the index of suspicion is high on the part of the clinician, then even a women over the age of 30 can get a mammogram done along with an ultrasound, and follow it up with an ultrasound or an image guided core biopsy. That is what is essential. So clinical examination, imaging, and image guided biopsy, I think, should be done for every single lump. uh, what I see is, even in younger women, we, like Dr. Poonam also said, what is alarming in our country is we are seeing young breast cancers. So the incidence of breast cancers in the age group of less than 40 is close to 15 to 20%. And it is, and I'm sure we all see our share of the 20s, young girls in 20s. They're far and few, thankfully, but we do see them, and they invariably think it is a fibroid. It's not just they who think it is a fibroid. A lot of time, clinicians, other than those who are used to seeing these lumps, tend to categorize it as benign even without doing a next investigation. So, because don't want to think that it is going to be cancer in a young girl like that. So I think that even younger women need to be very aware of themselves and should report a lump of recent origin.
Thank you, Dr. Geeta, for providing us with these insights. Also, in following up of that, I would like to know that there are so many people out there who think that biopsy se cancer फैल जाएगा. Like, there are so many myths. So, would you like to burst some myths that help people to aware about it?
So, biopsy, there are cancers in which we do not do a biopsy, but breast cancer is not one of them. In fact, you would be hugely disadvantaged if you do not get a biopsy done, because our premise for starting treatment is a biopsy. If we do not do a biopsy, if we do not do markers on the biopsy specimen, we would not be able to know how to. So just as Dr. Poonam, I'm sure, would vouch for it, if she were to not know the receptor status, she would not know what systemic treatment to give to that patient. So it is very, very important to do the biopsy. And it is a myth that putting in a needle into the breast is going to invariably cause the cancer to spread. And we all have our set of patients who have lived long lives as testimony to the fact that a biopsy needle does not cause breast cancer to spread. And other than biopsies, even mammograms are blamed for, you put pressure on the lump and the lump will kind of, start traveling once you've done a mammogram. And then, myths like underwire bras, black bras, and what have you, the antiperspirants and deodorants causing an increased risk of breast cancer. So we have all actually put it to rest, but the WhatsApp university often raises its heads every now and then and tries to confuse people. But we must know that that is not the truth. There is no fact to it.
Thank you, Dr. Geeta, for busting all these myths. Moving ahead with the discussion to the screening and self screening techniques, I would request Dr. Navneet to please tell us what are the current recommendations for the breast cancer screening in terms of age and frequency.
Okay, so screening, I think, is a very tricky issue to address. It has to factor in many factors, many things like what is the rate of cancer in a particular population, right? What are the resources which are available? And if they have the facilities to really screen and take the necessary follow-up action. So countries which are developed where population-based screening has been part of the programs for ages, they start at the age of, even that is variable from country to country, but usually they will start from the age of 50 because around that age their patients of start breast cancer start peaking. And there may be protocols of yearly mammogram, or there may be a protocol for once in 2 years kind of a mammogram. For India, we don't have any mass screening program per se for multiple reasons. One is that even though we have cases which are rising much in number, we still are much less compared to the Western countries where rates are 3 times, still more than that. So first of all, we have a large population. We don't have that high risk in the population. And most of all, we don't have the facilities to offer quality mammogram, do the proper reporting, and then take an action. Because if you do something which is half cooked, it does more damage than help the situation. So we have to look at cheaper alternatives which are viable, which can be relevant to the patient population of our types. So the other ways to screen for breast cancer is simple clinical breast examination. And there have been studies which have shown that this clinical examination, which is done by a trained person, it may not always be a doctor, it may be a trained paramedical health worker also. If they are trained how to do a clinical breast examination, then they can pick up the disease early. And these kind of the examinations can be voluntarily sought by the patients themselves, or they can be some camps and those activities which increase awareness and does the screening on in a local population. And that can be done once in 2 years from the age of 25 till the age of 39, and post 40 the recommendation is it should be done every year. So that is one recommendation. Other than that, self-examination, I think, which is one of the most relevant, cost-effective tool which is available to patients in our population is self-examination. So they need to be aware about the common problems with which a cancer may present, be aware how their normal breast looks and feel like, and also know how to do the self-examination. It's a technique which has to be done in a specific manner. So one can always look up at the video whenever you go for a clinical examination. You just ask the person to explain that how should I touch my breast, because eventually breasts are glandular organs. If they are held in a certain way, they will always feel like there is a lump. But if they are examined in the proper way, then only when there is a lump will be picked up as a lump. So self-examination was a tried and tested method, which is been, I think, recommended by most of us all the time. But even to take away the anxiety which may come with the self-examination, because when we explain self-examination, one is looking for cancer, and if they find something, it is taken as it is there, right?
Yeah.
So what is a normal breast? What is a normal breast? I think that awareness is more important. When you just check, all is good, none of these things are there. So I'm not looking for a cancer, but I'm looking for my breast which look normal, or there is some problem which may need attention. So it takes away the over anxiety and stress which may come with self-examination. So these are, I think, just very fine differentiating features, but eventually the person should be looking at their own breast. So this is the recommendation, say, for an average person who doesn't have any of the risk factors. And I think, as Dr. Poonam and Dr. Geeta touched upon, there are many known risk factors which increase a woman's risk. So these kind of people should be in more regular screening programs, and based on what kind of a risk they have, if they have a strong family history, if they have some first degree relative who has been diagnosed at a younger age, there are many other cancers which come in clusters. So it is not just a history of cancer of breast in the family, even that of a gynecological kind of a cancer or cancer in males, they are also clustered with a certain gene
Hmm.
mutation. So if some such history is there, so patient should be talked about any kind of cancer in the family, first degree, second degree relatives. If some such thing is there, or some known risk factors like if somebody has not got married, hasn't had children, these again increase the risk of a person. And there are some factors which are not very strongly associated, but they may increase the risk, like obesity, smoking, alcohol, intake of oral contraceptives, or hormone replacement. So these histories, if they are there, and most importantly, any history of radiation in the younger age between say 20-30, or a breast biopsy. So these are some symptoms, these are some histories which we associate with the higher risk. And if some such thing is forthcoming when we talk to the patient, then we have to tell them that they need to be kind of assessed for their risk, and based on their risk assessment, those who are considered very high risk, 20% and above, we put them in a we recommend a very regular screening program. Those who are average risk can just have the examination or the option of a mammogram if that's their personal choice. And coming next to that, if those who are having even higher risks and very strong kind of a tendency in the families, then we even recommend a genetic screening, genetic testing. So all these
Yes.
tools are available, and we have to tailor it to the patient's situation or a person seeking an opinion, because many women will come to OPD and they want to know whether they should have a mammogram or not. Starting the question is that, or some will come with would want a mammogram done and a reporting based on that. So when
Hmm.
we advise for screening, we have to tell them everything, that you have to decide whether you want to go for it, because if you are considered a high risk and a report comes, then are you ready for the next action, right? So I think we can categorize screening for normal risk, moderate risk, and high risk. Our recommendations are tailored to that, and it is a decision between the patient and the doctor to decide what is the best thing for them. So high risk should be having a regular screening and maybe some therapies to keep the risk low. Moderate risk can be people who are in closer observation, clinical examination. And I think average risk should be aware and do self-examination.
Yes.
That is probably roughly a applicable protocol for Indian population.
Thank you, Dr. Navneet, for explaining this wonderfully. Moving ahead with the discussion to Dr. Poonam, I request you to please tell us about the technique for the self-examination and what major mistakes girls are doing while doing the self-examination.
So self-examination, as Dr. Navneet said, that it is very important in our country when we talk of resource-limited issues. So a self-examination starts at 20 years of age and above. And every girl, in fact, once she attains menarche, she should do breast self-examination, because the breasts keep evolving over a period of time. What the breast structure was at 20 years is not different from 30 years, is different from 40 years, and so on. So, breast
Yes.
evaluation should be done in the first week after periods, because that is the time when there is not much pain in the breast. Many young girls have pain just before periods, and after periods occur, the breast pain comes down. So, that is the best time to do so. And self examination consists of two main things: inspection and palpation. Inspection is visualizing oneself in the mirror, and palpation is using the fingers to feel the breast. So, inspection should be done in various postures, and that is basically to see whether both the breasts look how they used to look earlier, whether they are symmetrical, whether there is one breast which is looking a little different. So, there should be, unless they know what is normal for them, it is difficult to find out what is abnormal for them, whether the nipple areolar complex, whether that is how it should be, or whether it is pulled in position. So, or if there is dimpling of the skin, or skin at some place is looking little reddish or inflamed or swollen. So this is what you find in inspection. Then comes palpation. Palpation takes into account these four finger pads that we have, because these are the most sensitive portions of our body. And with these small circular rotatory movements of the breast, they can either do up and down, move up to down, and then like this going in this vertical manner, or they can do it in spiral circular manner, starting from the center and slowly coming out, or they can do in say radial manner, going from center to out radially and outside to inside radially. So with small circular movements, the entire breast should be spanned with the fingers. And what they are looking at is if there is a lump which is felt, which is moving or not moving, or there is a thickening, or there is a hardness of the skin, or there is even pain which is persisting. So, pain, most of the times, the breast cancer lumps are not painful, but persistent pain at a particular site, even though it is not a symptom as such of breast cancer, they should take an opinion from the doctor. So, and if there is a spontaneous nipple discharge, that is also, especially if it is blood stained, could also be a symptom of cancer. And the breast tissue actually is not what we see as the breast, but it is the examine the area that should be examined is right in the middle from the breastbone to the underarm area laterally, because the tail of the breast goes towards the underarms. Down, it should be till the fold of the breast where it meets the abdomen, and up till the clavicle, that is the collarbone. So, this entire area, which is an imperfect square, that entire area should be checked. Many times women miss the inframammary fold, as we call, that is where the breast meets the abdomen. So that fold which is there, most of the times women miss examining that area. And even though they say that they were doing breast self examination correctly, that area may be missed. And this is also true for women who are pregnant or lactating, even though they may not be having periods, even postmenopausal women, they should also do breast self examination, and they should assign a particular day or a particular week of every month to do breast self examination, because they are not having periods. That should not be an excuse that I was told that in the first week after periods the breast should be examined, but I am not having any periods, so I didn't know when to do. So they should also have 1 week or a day allotted every month to do breast examinations.
Thank you, Dr. Poonam, for explaining this very wonderfully. And this is really valuable for the people to understand about the self screening part. Moving ahead with the discussion to Dr. Geeta, can you please provide us with these insights on are there any new technologies or methods in the breast cancer screening that show the potential for improving the detection rates?
So if you ask me what is conventional stays, and that is, mammogram continues to be the one method by which screening should be done. There are other methods that have come in, but they're actually still to be validated and to be proven of more benefit than mammograms. So you have thermal scans, you have infrared imaging, and such stuff, but there is no real validation, and the sensitivity and specificity of these tests are not as good as you would with a mammogram. So mammogram will continue to be, till the time we have a better alternative, will continue to be the method of choice of screening women over the age of 40. So we will always be caught in this dilemma as to how to look at the breast for women who are younger, because in younger women, a mammogram is not going to be of value because of dense breasts, and you would not be able to pick up any abnormality in dense breasts with mammograms. So there, you have to rely on things like ultrasound. Although ultrasound is not touted as one of the screening modalities, but if it comes to that, then, and because it is operator dependent, and you may not always get the right kind of information. And then there is MRI. Again, MRI not be used as a screening tool unless for specific groups, which is those with a very high family history risk, and also in those who are suspected to be carrying a mutation and are and are on very close surveillance. And when I say high, very strong family history, suppose there is a lady who's had breast cancer at the age of 35, then you would expect her daughter to start screening 10 years prior to her diagnosis. And then if you start screening very early, that is when an MRI screening is recommended. Other than that, for the mutation carriers, you would be doing alternate mammograms and MRIs every 6 months. So that is how that is the technology that is available as of today for screening. We will see how the other methods which are being investigated pan out in the future, and maybe we will have a better alternative to the uncomfortable mammogram.
Thank you, Dr. Geeta, for providing us insights on the screening part. Moving ahead with the discussion to the importance of methods and early detection and diagnosis, Dr. Navneet, can you please explain why is early detection is so crucial for improving the outcome in the breast cancer?
I think any illness which is picked up early has always a better outcome, and this is very true for breast cancer also. So, early detection is helpful for decreasing the invasiveness of the procedure, right? When the patient comes with an advanced disease, we have to offer more radical surgeries. But if they present early, they can get away with surgeries which don't even, which are not even apparent. So, after surgery, nobody would know that patient has had undergone any treatment for breast cancer. So, it causes less mutilation of the body, preservation of body image. That's one advantage. But I think the biggest advantage is that patient has a much better outcome in terms of being disease free and the survival if they come at an early stage. In countries where screening is a regular practice and patients are educated and they come early, um, once the diagnosis is made, their survival rates approach 98 to 100%, right? Whereas in India, where patients are generally coming with advanced disease, we have seen a change. It is especially happening in metropolitans that we are seeing patients are coming at an earlier stage, screen detected. So that is a, I think, positive change that we have seen over the last decade. But still, we see a big number of patients who come with an advanced disease. So advanced disease means poorer prognosis, more intensive treatment, more toxicity of treatment, more expense, and everything is more. So coming early is, I think, a blessing for a patient. If somebody has to have a cancer, if picked up early, they will have everything near normal. And so that is the importance, that they can expect a near normal lifespan if they report at an early stage, stage 1 or 2. And stage 3 is little more advanced, and stage 4 is already something which is spread into the body. Fortunately, with treatments which have been developed and research which is there in this field, we are seeing patients surviving even with advanced disease for much longer periods. So outcome is not as grim. It is not a death sentence anymore as it used to be earlier on. But still,
Yeah.
if you pick it up early, you end up paying much smaller price than when you present late.
Thank you, Dr. Navneet. In following up of that, can you please provide us with current available methods for the early diagnosis and how effective they are?
So as I think we have been discussing so far, Dr. Geeta talked about screening, and screening by various means: mammography for patients who are people who are 40 and above, and other modalities like ultrasound and MRI when they are younger. So these are the screening methods by which we can pick up the disease early. And if the disease is picked up early, then we do surgeries which are far less invasive. So we don't have to, we just get the tumor out and we just check it out under the microscope that all the margins are clear. So we have not left any disease behind. Even for the spread part, normally when the breast cancer is there, the underarms or the axilla is the place where they first spread to. So even treatment in that area can be very minimal. That by looking at just a couple of notes, we can decide what not to, what patient needs and what aggression or aggressive treatment can be avoided. So screening done by these methods helps us pick up the disease early. And even those who have been without screening presented with a lump or a visible sign of a malignancy, uh, we then have to see that disease. There are multiple tests to look for the extent of disease. Normally, we want to be sure that it is just within the breast. It has spread
Hmm.
in the region what we call as local, that is in the underarm area or in the neck areas, or whether it has gone into the system. So there are investigations by which we will be able to elicit this information that whether the disease is localized, is a local regional disease, or it has already spread. And based on the stage, we then, after this kind of a workup, we have found a lump, we have done the assessment part, triple assessment, um, doing imaging required, which is for that particular patient, taking a biopsy. And after confirming the diagnosis, knowing the extent, it is within the breast or beyond the breast, we have to plan a treatment for the patient. And as on date, for every stage, there are multiple options. So there is not a single best treatment available. And many of patients come back to us, especially people who work in government setup. They want to know that they have been given this advice by one doctor, the other
Hmm.
advice by another doctor, and which one is right. They are very confused. So they need to be told that for these situations, there are no right one answer. There are options to choose, and which sequence is followed is based on many things: your tumor behavior, your resources, and your preferences. Some people would want just do the simplest thing, get the tumor out. I am not bothered about cosmesis. I just want a minimal kind of a treatment, and it should be done in one go. Some people would not be that kind of not concerned about body image. They would be very much concerned to preserve an image, and want to hide the fact that disease has happened to them. So we discuss the options, and those who come for a second opinion, I tell them they all are fine. These all options are valid. You have to have all these treatments. In which sequence you get them is what is going to matter, based on many factors which are to be factored in. So treatment can be for any breast. I think I might be just going beyond the question. I actually have missed out what exactly was your query.
No worries. Just please continue. I was talking about, I mean, how the early diagnosis is really effective.
Yeah. So early diagnosis helps us pick up disease early. So when it is within the breast, or maybe it has not even yet started, it is just in a pre-invasive stage, what we call as in situ stage. So it is not even become invasive. So screening helps us pick up those kind of lesions, even some lesions which are called high risk. So they are not even pre-invasive. They are not going to develop into a cancer definitely, but their presence indicates that there is a certain instability in the tissue, and they are likely to have cancer subsequently. So we are able to pick up high risk lesions, non-invasive stage of cancer, as well as an early stage of invasive cancer, and the extent of spread which may be there, because nodes in the axilla can be very well assessed on these imaging modalities. When the disease has gone into the system, we are not looking at screening tests. Then we are looking at investigations for the purpose of staging. So screening helps to minimize the extent of invasion which is required to get the disease out. I hope
Thank
I
you,
have
Dr.
answered your
Navneet.
question.
Yes,
Yeah.
yes, definitely. Thank you, Dr. Navneet, for these insights. Moving ahead with the discussion to Dr. Poonam, can you please explain, I mean, how health educational initiatives can be curated or designed to enhance the public awareness about the importance of early detection when it comes to breast cancer? Dr. Poonam, can you please unmute your mic?
Sorry.
Yes.
As we discussed so far, awareness is the key. So, the main thing that we can emphasize again and again is awareness, awareness, and awareness. And our duty is not just once to make the population aware, but also to keep reinforcing. So we have to keep reinforcement initiatives also ongoing. So information awareness should be disseminated. Some ideas of how it could be done is by giving, say, we put brochures, pamphlets, posters. Sometimes we get in the newspapers brochures and pamphlets about what is the importance of knowing breast cancer, screening techniques, risk factors, and that could be important in disseminating information. Social media campaigns, like how you are doing right now, utilizing social media platforms to share educational content, survivor stories, information about screening, how to do it correctly, when to report to the doctor, when to go to the doctor, encouraging discussions and question and answer sessions with healthcare professionals who are experts in the subject to address concerns, dispelling myths also, as Dr. Geeta told, how people have myths about mammogram disseminating breast cancer, even if it was in an early stage, how pressure on the breast may allow the cancer cells to disseminate. then even partnership with local clinics and hospitals to provide free or low cost screenings, or even educate patients about the importance of regular checkups. So when the patients come for some other issue to a clinic or hospital, they are like your you can just catch them and tell them about importance of screening of breast, importance of regular checkup, even educating healthcare professionals, the general practitioners, or even say different specialities, ophthalmology, dermatology, gynecology, who or even general practitioners, registered medical practitioners, on effective communication strategies to convey the importance of early detection of any cancer, especially breast cancer, to patients. Community outreach programs such as healthcare camps, which was discussed earlier. There have been many hospitals who run mobile clinics to offer free screening in underserved areas in the rural population, to reach populations that may have limited access to healthcare services, and training on self examination. We talk about self examination, but it's easy to talk, but when the woman starts practicing, they find 101 problems that come. But training on that, then involvement of breast cancer survivors who are there to motivate people to go ahead and do the screening, and if there is a diagnosis of breast cancer, not to fear and go ahead with treatment, and the involvement of support groups, which can be very helpful in increasing and motivation, improving the confidence of normal population that okay, I should go and get myself tested.
Thank you, Dr. Poonam, for such wonderful recommendation. And I think this really should be taken action to spread as much as awareness we can. Moving ahead with the discussion to Dr. Geeta, I would request you to please tell us about the genetic testing and the risk assessment part when we talk about the breast cancer, how it's related to that.
you, if you were to talk about risk assessment and genetic counseling and then testing, I think there is a lot of gap in the understanding and the understanding not just of the patients but also in the understanding of health professionals, because we are all kind of evolving with what is happening in the genetics aspect of not just breast cancer. I think every other every other cancer. So if you talk about risk assessment, so if there has to be certain risk assigned to you before you even talk about genetic counseling and testing, and all this is usually done by a genetic consultant. So as a clinician, I would know that she's had a couple of breast or ovarian cancers, or maybe one of pancreatic or a male breast cancer. So I kind of figure out these issues, and then I kind of say, okay, look, why don't you meet the genetic consultant to understand your risk. So she's a person who will assign a certain risk to you and then say, well, you are in line to get genetic testing done. And unfortunately, what we are seeing in our country is that genetic testing has become an over the counter test, something like a CBC, which is kind of very dangerous considering that genetic tests have huge implications. And this has to be uh, spelled out to the patients before they kind of choose to do a genetic test. And who should be tested first is also very, very important. So if suppose there is a mother, a first degree relative who's alive with who's completed a treatment of breast cancer, she's alive, she's the one who should be tested first. Because if you were to detect a mutation in her, then you would be looking at that mutation in the a person who's sitting across the table and asking you for a genetic test. So it is very important to do it in the right person. And then, like I said, once all this has happened and this person wants a genetic test, she should be counseled right. So once you counsel, so when I say pre-test counseling, very, very important, because then is the choice of a test or not. So when you do a pre-test counseling, you will say that, well, if your test turns out to be positive, what? And what if it is negative? So if it is positive, there are certain implications that the person must understand completely, which can range from close surveillance to prophylactic surgeries. And if the person is not in a mental state to receive such a treatment subsequent to a positive test, you should not be contemplating a test at all. So I think we often don't give this opportunity to our patients. And I find that a lot of patients say, I got my BRCA test done and it was negative. So thank God for it, it was negative. But what if it is positive and you do not know that these were the implications? You could be in a state of anxiety for the rest of your life if you don't make the right choices. So it is very, very important. It is very important pre-test counseling, testing, and then post-test counseling. And then that is when you can make sense of it. And also, if there is a patient who's got breast cancer and who's well within a right to undergo a genetic testing, especially the younger ones, we would always recommend a genetic test, especially if you're under the age of 50, irrespective of the subtype. They should also understand there are two aspects to the testing. One, we want to know whether you're carrying a mutation or not. Two, we want to be able to give you a certain type of treatment which is possible to give if you're carrying the mutation. So it's not just about testing and finding out whether you're positive or not. It is also about treatment that can follow genetic testing. So a positive test. So all these aspects need to be laid on the table for the patient to decide and pick and choose. And we must understand there are a huge lot of social implications around genetic testing also. There is a mother who's had breast cancer, aged 40, triple negative. There's another cancer in the family, and there is a young daughter who's of marriageable age. The mother would choose to decline. I don't want to know whether I'm carrying the mutation, because tomorrow my daughter would not get married if somebody were to know that I was carrying a mutation for breast cancer. So we must understand it comprehensively before writing off a test on our prescriptions, which is the easiest thing to do.
Thank you, Dr. Geeta, for providing us with these insights very positively. Moving ahead with the discussion to prognostic testing. So, I request Dr. Navneet, can you please provide us what is the distinction between the prognostic testing and the predictive testing in the context of breast cancer?
So these tests kind of tell us what should be the patient's, what should patient be explained about, their risk, their outcome, their prognosis. So we categorize them in these two categories based on whether they will have a bearing on the treatment that we will plan for the patient. So those factors which tell us what the tumor's outcome is going to be like without having any direct bearing on the treatment outcome, we call them prognostic factors. And those which tell us that this kind of a treatment is going to work for this particular patient, they are called predictive. So there is a very fine difference. More or less, some of them will be overlapping in both the categories, right? They will be also telling us what is the prognosis of this patient because they are having that particular biomarker, and this kind of treatment is going to be useful for them. For example, we have these biomarkers called estrogen ER, PR, HER2/neu, Ki67, and now more and more are being made into clinical practice. Like there are some markers for immunotherapy agents like PD-L1, PD-1. So these kind of tests tell us what is the tumor behavior and what kind of treatment can be tailored to them based on these reports. Then there are some factors which don't really tell us exactly that this kind of treatment is required, but they do tell us that this patient is going to have a more aggressive disease and a more likely poorer outcome. So distinction, I think, is not very significant, but say a tumor size or a lymph node status or a lymphovascular invasion or extensive DCIS, all these things are prognostic factors. Predictive factors, ER, PR, biomarkers, they are prognostic as well as predictive. And then we come to the testing part, prognostic and predictive testing. So it is not just about these kind of tests which tell us what to plan treatment for them, what kind of treatment for them. There are certain tests which tell us what treatment can be avoided based on their um, signatures, their genomic profiles or tests. So there are multiple prognostic tests which are available. They give us certain kind of scores in a particular patient based on multiple factors put together. So these are kind of algorithms which look for many mutations, somatic, genetic, whatever. And based on that, they tell us this is the risk of this particular patient of responding to this treatment or a disease coming back if this treatment is given or not given. So these kind of prognostic testing is available, and these are mostly multiple gene panels. So like you may be familiar, people who are listening may be familiar with Oncotype DX and MammaPrint and Canasis. These kind of multiple gene panels are there, which are again uh, testing done to know whether these patients can be offered less aggressive treatments. So those patients who have a lesser risk of a spread in the body, they can be given the option of no, not go for chemotherapy. They can just be put on a hormone treatment, which are much less toxic to the body, much well tolerated. So this kind of understanding of the tumor biology, the behavior of the tumor in terms of how it is going to multiply, how it is going to spread, what is the heterogeneity within that tumor, understanding that and utilizing that information to plan treatments or at least tell what kind of outcome is expected is what this prognostic and predictive testing is about. So as I asked you in the beginning, I'm not sure whether we are talking just to lay people or people who are very much into medicine. So I'm keeping it rather simple. It may sound to people who are into medicine a very basic kind of information. So we can have multiple gene panel testing, which have become integral to the patient management part, especially those who are early breast cancers, who are node negative. These kind of testing is done to see if they can be, if we can avoid giving them chemotherapy, or certain kind of additional treatments like immunotherapy agents can be useful for them if first line treatment or second line treatment is not completely able to control the disease.
Thank you, Dr. Navneet, for providing us with the information both thoroughly and effectively that when laymen can also understand about it. Moving ahead with the discussion to the treatment part, I request Dr. Poonam to please provide us what are the current standard treatment for breast cancer and how they have been changed in the recent years.
So, the standard treatment for breast cancer has generally been in early stage surgery, and depending on the stage, addition of radiation or even of the type of surgery, what has been done, addition of radiotherapy and systemic therapy. In systemic therapy, we have chemotherapies, hormone therapies, and even targeted therapies. There are targets such as HER2/neu present on the cancer cell, and if that is positive, we treat them with anti-HER2/neu treatment. So these are the standard treatment options for breast cancer, that is decided on the stage of breast cancer and on the type of breast cancer, whether it is hormone receptor positive or whether it is HER2 positive or whether it is triple negative. So these are the standard things. But now what we are getting more and more into is personalized medicine and targeted therapies, which are transforming breast cancer treatment. As Dr. Navneet said, that there are genomic profiling tests available, which are often used for very early breast cancers to understand whether the cancer is aggressive enough to receive chemotherapy, or it is a relatively silent type of cancer which after surgery may not require chemotherapy. So these genomic profiling tests, as she told, which are also known as risk of recurrence scores, such as Oncotype DX or Mama Print or Endopredict, Prosigna, or Canacist, or these are many tests which are available actually, which can tell whether the patient is at high risk of relapse or low risk of relapse. High risk of relapse means they should get chemotherapy apart from the other standard of care approaches. Then HER2/neu positive breast cancers, there are many new drugs which are available apart from trastuzumab, even for early disease, such as with trastuzumab, we often have adpertuzumab, the drugs such as TDM1, which are all standard of care for HER2 positive, even early breast cancers. So targeted therapies, they show higher response rates in specific patient populations, leading to better overall outcome. They have less impact on healthy cells, so less side effects, and often they have synergistic effects along with the other systemic chemotherapies or hormone therapies or other immunotherapies as well. So these are all the novel therapies that have come up, which improve patient outcomes and reduce the side effects, especially in early and advanced disease both.
Thank you, Dr. Poonam, for providing us with these insights on the treatment part. In the end, to conclude, I request Dr. Geeta to please provide us with any recommendations or advice you want to give to the patients out there who are newly diagnosed with the breast cancer or are at the verge of this disease.
So, for those who have been recently diagnosed, I know it is very, very tough. We can be on the other side of the table and keep thinking it is okay, but it is not okay for somebody who's been recently diagnosed, irrespective of what stage they come to you with, because they're when they're much older and past the disease, even the early ones, if you ask them, they'll say, Dr. Geeta, हमें कैंसर का लेबल लग गया था ना, तो कैंसर का मतलब तो it's like quite earth shattering. And the other thing about cancer is that it is not just about the patient, it is also about families who get involved in this whole process. It is a tough process, but I think they require a lot of handholding. It is not an easy disease to deal with. It takes away a lot emotionally, socially, financially, and it kind of really puts you in a corner. It is not easy, so that is why it is important to handhold them through the process of treatment. So I would say that one should not fear the disease, because and if you are feeling terrible about having been diagnosed with breast cancer, that's a normal reaction. Don't think it is abnormal. Don't try to hide your emotions and think you will be able to deal with it. It is okay. It is okay to let your guard down, and if you feel like crying, it is fine. That is the way one internalizes such a tough decision, such a tough situation. And then you have to come out of this phase of denial, grief, and then start doing the right things for yourself. So once you start doing the right things, I always think that it's the first step that is tough to take, because I see patients transforming quite quickly. Suppose one has been offered surgery, she undergoes surgery, and when you meet her after surgery in the post operative period, you find a slightly different person from the most quiet and non communicative patient in the beginning. And then once they go through chemotherapy, so whenever I would meet a patient after 4 cycles, so I says four to चार हो गए, अब चार ही बच गए ना, मतलब पहले तो 8 थे. So you have to keep pushing them, encouraging them. So don't worry, you will have a lot of side effects of the disease. These are all temporary. You must realize. So often talk about hair loss, and then we will say that hair loss to hoga. So if they ask me, I don't try to cover up. I say yes, it will happen, but they will come back, and possibly you will have a better mop of hair than before. And this is usually the case. They don't believe you, but when they come back after treatment, they say, "आपने ठीक कहा था, बाल बहुत अच्छे आ गए, आपकी तरह बाल आए." So there are a lot of things that patients go through. You just have to hang in there. It will come to an end. Think that you have given away 1 year of your life in penance, and you're going to come back stronger. I have not known it doing anything else. The fear remains, and as time passes by, the fear also fades to a large extent. And support groups, do seek support. Don't uh, feel ashamed of seeking support. I always say this: if you need help, please ask for it. If you're feeling down and out, say so, because then we will be able to help you. If there are issues arising out of treatment, vocalize, because there is help for all of this. And I would say it is a tough journey, but it is not unsurmountable. And if somebody says मेरी लाइफ पहले जैसी हो जाएगी, मैं तो कह रही पहले जैसे नहीं, पहले से भी बेहतर हो जाएगी.
Thank you, Dr. Geeta, for such wonderful recommendations and the advice with this positivity. In the end, to conclude, our objective for today's discussion was to explore and emphasize the importance of breast cancer by integrating insights on recognizing the signs, symptoms, detection, screening methods, and the treatment options. And I'm confident that our experts have addressed this crucial topic comprehensively and effectively by presenting the information in both thorough and accessible way that the layman can also understand. So I would like to extend my gratitude to all the panelists for this insightful contribution and for sharing your expertise with us today. Your participation has been really valuable, and we deeply appreciate the time and knowledge that you have shared. So thank you so much for contributing to this important conversation.
Thank you
Thank
so
you.
much.
Thank you.
Thank you, Sumedha. Thank you
Yes.
so much. And thank you, Anne, for inviting me.